you're on a very different dimension of the health problem. So what do you have to say?
Um, Thanks, Amita. The role, I think you were asking about the role of the state, and in case of surrogacy, which is what my book is based on, the state uh, exists as a moral authority, and that is part of the problem because the state is intervening in in regulating a practice from a dimension which it doesn't need to regulate it from. The whole conversation on surrogacy is about the surrogate and her body, but from a different direction. It's not about medical regulation. It's not about looking at how IVF doctors or IVF clinics need to be regulated. It's about who can be a surrogate or whether a woman should be a surrogate. I mean, these are moral, ethical questions which can be handled or must be handled, but only after the regulatory powers of the state come into action, which is not happening. So, for instance, the Indian Council of Medical Research draft Assisted Reproductive Technologies Bill, which there have been many drafts. The first was in 2008. Then the most predominant one, the one that's most discussed, was in 2010. And then the recent one that was discussed was in 2015. Was completely, which had a section on surrogacy, was pushed aside to bring a law on exclusively on surrogacy, which is called the Surrogacy Bill, which was introduced in 2016, which says that commercial surrogacy will be banned, but altruistic surrogacy will be allowed. As of 2017, the Parliamentary Standing Committee, Rajya Sabha Parliamentary Standing Committee, has actually questioned that bill at various levels, invoking questions that feminists, activists, civil society have been bringing forth about the whole question of reproductive choice and where does choice figure in all this, and why isn't the state interested in that? Why is the state interested in the moral question of whether a surrogate should be married, whether the couple who hire a surrogate should be married, what their sexuality should be? Why are these questions that should involve the state per se? Where are the questions about the IVF clinic malpractice, questions of whether the surrogate's health post birthing the child is taken care of or not? What about medication? What about the child's health? What about the couple? Where are these questions? So, for instance, if you've been reading newspapers, recently in Hyderabad, one surrogacy clinic was raided because they were housing surrogates together, packed in a hostel-like condition, which was unhygienic and unhealthy. And the High Court has come down very heavily on this. And at some point, the High Court actually suggested that the babies born to the surrogates would be given to the surrogates, leading to a kind of tension and anxiety because the surrogates are not there. They didn't enter the arrangement to take care of these babies. So we are at a point where the state's regulatory authority in case of surrogacy has such manifold, multifaceted elements, but the question of regulation of medical practice does not occur, does not figure in all this. Instead, we just get caught again and again in the question of commerce and intimacy, commerce and children, commerce and the family. And I continue to say this, and I'll keep saying this again, that the surrogacy bill and the assisted reproductive technologies bill is first and foremost about the family. It's got very little to do with surrogacy and with reproductive choice, or it's got to do with what the family is going to look like.
So my second question basically to both of you again is that in some ways both of you are saying that there are clear cut tasks which only the state can do and is not doing. Anindita is bringing in that it's doing that which it should not be doing, and what it should be doing, it's not doing. And both of you, the argument which comes in each book in different ways is that this way of the state operating has a disproportionate kind of an impact on it has a gender impact. I'm saying gender not just in relation to women, but I suppose also the more disadvantaged segments that, and I thought if you all could kind of amplify a little more on that, it would be helpful.
The issue of gender, is it all comes up in the context of the whole status of women that Indian society itself gives to the issue. And so we all know the kind of female infanticide, we all know the dropping sex ratios, we are all aware of the misuse and abuse of technology to get rid of the girl child. These are all issues that have been in public domain for a long time, and these have very much got to do with how society values its own women and its girl child. Now, this is where the state needs to intervene again, as I said, because it is here that the providers, that is those who own ultrasound machines and who have commercial considerations to influence their ethical obligations to continue to reveal the sex of the unborn child to the parents, even though they know that this may lead to infanticide or feticide, as the case may be. But then the state has been very weak. I mean, really, government has not been able to control the ultrasound industry. It's a very huge $18 billion industry in our country, and this goes on rampantly. But it also is the fact that the medical fraternity hasn't again taken this issue very seriously, and they continue to protect the doctors who are indulging in this practice. So this is a whole issue you have to look at, just not narrowly from gender and health. It has a lot to do with the societal values in which we look at this whole issue of gender. But let me just say one thing, that in the whole health spectrum, a woman, she belongs to the, say, a scheduled caste or scheduled tribe category, living in a very remote area, in a rural area, is probably the most vulnerable and the most disadvantaged of all other groups or population groups that we might have. And next to this, and the greater vulnerability, I was talking about poverty, but when I joined the NACO, the National AIDS Control Organization, and I was Director General there for 3 years, I was amazed to see the kind of vulnerability that other groups like sex workers, who are largely women, or even men who have sex with men, the homosexual communities, or the drug addicts, the kind of extreme vulnerability that they face, and particularly the sex workers. It is amazing why the feminist movement in India has not been supportive to sex workers, because 90% of the sex workers that I have had an opportunity to interact with all got into sex work only out of compulsions to save their child who's dying or whatever. I mean, those kind of compulsions, not out of choice. And so when a society compels a woman to get into this kind of sex trade and then abuses her and does not give her the space to live her life in whatever manner that she's chosen to, it becomes a double whammy for them. And the state never reached out to these hidden populations till such time that HIV/AIDS really came into being. So health sensitivity to women is something that we need to still work on.
So gender is, the connection between gender and surrogacy is very insidious. I believe it's because the state has always been thinking about population, and that women in India reproduce so much. The population policy has constantly marked the collective mindset in India. Any conversation on infertility gets pushed aside. The moment a conversation on infertility gets pushed aside because you don't believe infertility is a public health issue or a health issue per se, the connection is the connection with surrogacy becomes equally problematic. So in terms of gender, surrogacy suffers from huge public malaise in a way which at first judges the woman because she's a mother, quote unquote, who's giving up a baby for compensation, And then there's this connection with how there's the other woman in the picture who's an infertile woman who cannot have a baby, who's hiring a surrogate. So the judgment and the moral ethical issues come full circle on the two women. And that's problematic. Gender figures in a very big way. It figures in the way in which women are constructed within the debate. It figures in the way in which sexuality and gender are linked. So this whole conversation about gay couples coming in to have babies. In 2013, a Ministry of Home Affairs note banned they only allowed heterosexual couples married for 2 years to come to India, foreign heterosexual couples married for 2 years, to have babies through surrogacy. So there was this blanket silent ban on the gay community coming in from abroad. We're not even talking about the gay community in India. So gender, sexuality, identity politics come together in a very problematic, complicated way in this. And the crux of the debate is on motherhood, and how motherhood is this moment of, if you look at all the Hindi films on surrogacy, and there have been many, the most popular being Chori Chori Chupke Chupke, the fact that the surrogate can only be the sex worker and nobody else means that only a fallen woman can fall into that, can take up that role, right? So if you're coming with that kind of popular mindset, and then you see women doing surrogacy who are not per se sex workers, you bring in the same stigma into the discourse. So motherhood, sex work, surrogacy, all of this gets enmeshed in a very problematic way. And gender is a very, very important part of the discussion, but there's no nuance in the discussion. And that gets relayed in different ways in which we see the surrogate, in which we see the woman who hires the surrogate, in which in the way we see couples, infertile couples wanting to go into surrogacy. So the whole, the way in which surrogacy is sold by infertility specialists is also to tell society that, these are, the infertile couples are anyway stigmatized. We are helping them have babies, to have social recognition. It's a huge problem. We have to understand that aspect of the debate as well. The moment, feminists and many of us in civil society say, oh, there's adoption, we have to look at the other side as well as to why an infertile couple should only adopt. Why shouldn't anyone else adopt? Why shouldn't all of us adopt? So the idea of fertility, womanhood, motherhood and families gets enmeshed in a very interesting, complicated way. I keep saying this, but it is because of the way in which commerce and intimacy collide in surrogacy, and that's problematic to the core.
All right, the organizers tell me that it's your time now. I have 5 more minutes. Okay, then I have a question before the audience question to both the speakers again. And I'm sort of like wanting to focus attention on 2 dimensions which are like the subtext of their books, which are not explicitly there, but need to be talked about. To Sujatha, I wanted to know that Sujatha, if you look at her book, she's given a very elaborate kind of a mandate to the state on what they should do. She's also kind of, through her book, explained why they should do what they should do. But the subtext is how we can make them do what they should do. And I think that's a question that as people we continually want to know that, all right, what is it that we need to do to make the state do what they have to do? To Anindita, my question is basically that you have spoken about every single stakeholder in the whole surrogacy transaction. The one, I would say the one silent voice or one kind of stakeholder whose voice is not really explicit, it's again a subtext, it comes in certain parts of the book, all right, is what about the child? The child who comes out of this process, what is it that we need to look out for there? What kind of discourse creation, what kinds of rights formulation? That's something that one would want you to speak on. So, Sujatha.
It's been very paradoxical for me. Almost there's no household, sounding very Buddhist in this manner, that there's not one household that has not seen a doctor or suffered a health ailment. And yet, health is still not in public discourse. And nobody really bothers. I mean, we are constantly at home, we are whining about health and lack of good doctors and hospitals and so on, but no one really gets to demand from the state that the health system should work well and decently. So this is a paradox, because democracy works on people's demand and people's perceptions. And health sector, unlike any other, has, because of this absence of a demand from the people, has really suffered for want of good leadership, and it has suffered for want of funding. India is one of the 15 countries which spends 1% of its GDP on health, which is abysmally low. So having said that, the issue of what should the state do, or what is to be done, very briefly, my answer would be that I think it's time that we really involve the people in health policy making, in health formulation, and people become active participants in this whole health dialogue. I think it's very, very critical to engage with the community and health. You might think it sounds very obvious, but actually people sitting in the policy making chairs, it's not very obvious. Even for me, I spent 20 years in the health sector, but this reality and the importance of this factor, democratization of health dialogue, really hit me when I joined NACO, the National AIDS Control Organization, because that was one disease, HIV, could not have been contained. The incidence fell by 66%, highest in the world, in India, where sex is such a taboo subject. Even then, despite that constraint, we were able to make a success, is largely because next to me, I'm an additional secretary in the government, but next to me would be sitting a sex worker, telling me why my guideline is wrong. So till you engage the people who are really affected, till the people are engaged, we will never be able to get a decent health system. So when in UK, health was being privatized by under Tony Blair, 1 million people marched. 1 million, that's 10 lakh people marched saying, you will not touch the national health system. It is for us, and you're not going to privatize it because we don't believe in the private sector. Is that kind of activism available? And until and unless this happens and the government is forced to dialogue with the people in the kind of health system that we need to have, I'm afraid that is one of the main things that a state should be doing, is to engage with the people. Unless and until we do that, I'm afraid that we can take very wrong turns, because health is one sector which is full of conflicts of interest, and the lobbying power of the commercial sector in the health space is very, very strong and need not necessarily be beneficial to the people.
Regarding children, I actually end the book with this letter that I got after I finished my research from one of the gay daddies, Australian gay daddies. And he writes to me that, he wrote to me saying that when our children grow up, they're going to come back to you in India to look up their family history. So I'm supposed to be the chronicler of their story, of their birth, which is a huge responsibility. I don't know if I'm up to it. But children, I think, and this is long-term research, children born from surrogacy are going to come back, and they're going to come back in search of more than their cultural roots. They're going to come back in search of those anonymous egg donors and surrogates who have given birth to them. And then we will have a huge minefield in front of us, because they're going to approach courts to rake up records. So children, we may ignore that aspect right now, but they're definitely very much there on the radar. They're all growing up. They're all going to come back. In fact, The Hague actually recognizes the growing traffic, as they call it, of surrogacy, international surrogacy. They recently, way back in 2014 actually, they convened an international meeting to draft laws similar to international adoption, to look at how surrogacy rights and identity to children being born transnationally through surrogacy should be figured out. Similarly, I mean, I've written about this a lot. Children are a very important subtext. The whole arrangement is to have children, but they become important, they're resurrected post their birth in an interesting way through the citizenship process. The citizenship process gives them identity. And the citizenship process that different countries get, now of course that's stopped because there are no foreign couples coming in, but the citizenship process actually gives different kinds of importance to different sets of biological stakeholders. And here biology is a very fluid concept. So for many embassies, for instance, Spain, Italy, France, the surrogate is the mother, whereas she has relinquished the child through the contract. It's not the adoptive social mother, it's the surrogate. So she has to again relinquish the child in front of the embassy so that the child can be adopted. Look at the irony of the situation. The child has to be adopted by its so-called genetic parents. So I'm looking forward to new research in a way when the children come back and I have to chronicle their birth stories all over again. I hope there'll be more to look at there. Thanks.
All right. So I had requested for questions in writing, but considering people haven't availed of that option, anybody who has a question to either of the panelists? Yes.
Thank you. Thank you for such a nice discussion. My question is to Sujatha ji. And I'm wondering if you could say something more about the model of care that you're championing, which seems to be a very welfare state-oriented model of healthcare. And when we are living in a historical moment, where welfare state protections seem to be rolled back across the globe, how do you kind of reconcile the?
Can you, the last part? The last part.
So my question is, like, living in a historical moment where the welfare state model is being rolled back across the globe, how do you kind of reconcile the model that you seem to be championing for healthcare in India?
Okay.
Hello, my name is Tarun. My name is Tarun. I'm a graduate student at Tata Institute of Social Sciences, Hyderabad. My question is to Ms. Sujatha. What do you think are the reasons behind the success of the HIV/AIDS intervention program, like the program which you led? I'm sure, yeah, you played a very important role there, and also the democratization which you mentioned in your speech also played a big role. So, other than that, what are the other reasons which led to this, and also the role? And what happened later, in the sense that there were issues of funding, there were stockouts, and I'm sure what happened later. Like, so the reasons behind it, like what led to the fall in the program after that. Thank you.
Sujatha, there's just a point you mentioned about having a dialogue with people. You look at just this aspect of National Medical Commission. This is in its second avatar, gone to steering committee. We have spent 10 years getting this in place. 2010, Ketan Desai was thrown out because of corruption. It's taken 8 years and we don't have a replacement for MCI. Tell me, is dialogue the only way out?
Yeah, hi, my name is Adarsh. My question is to Dr. Majumdar. How would the repeal of Section 377 have any implication whatsoever on the Surrogacy Act? And how would you go about mainstreaming the gender discourse into the drafting of such legislation and acts?
They're all very weighty questions, and I tend to talk a lot, so I'll try to be as brief as possible. I loved your question. What's going to happen in a global scenario where welfare states are receding? And that's something that's worrying us all. But as I said in my opening remarks, the choice and the option for state not to intervene is very limited. You're going to create disparities. You're going to only create a more society where there are more sick people. You cannot, I don't think, and I firmly believe in this, that health cannot be open to the private sector. The state has to intervene. Doesn't mean that the state is the only, government is the only provider of care. Any private sector can provide, but I must pay for it. The kind of, impoverishment in our country, almost 3 to 4% of our population gets below poverty line only on account of meeting the medical bills. So the question of the state calling this a welfare and a social obligation is not really the right one, because sick people don't produce wealth. And you cannot have the amount of premature mortality that we have in our country. The highest number of people dying are in a productive age group. You cannot get the population dividend that we talk about in terms of economic growth and development when your people are basically not well. So that is, I feel there's no option, and the government has to step in. There are various choices: provide the health care by yourself by setting up government hospitals, or provide insurance cover for those who are going to the private sector. But then you have to regulate the private sector. The private sector does have a conflict of interest in maximizing profits, and that should not interfere in a clinical decision making process. To HIV/AIDS, please read my chapter on HIV/AIDS, because I put my heart on that, and you will get to know all about it. You know, essentially, I was lucky. It was not really what work we did, why we could succeed so well in battling that infection. India took 25 years to bring down and contain the epidemic, like it has taken 25 years to eradicate polio. It does take that long. And this was particularly difficult because you're dealing with the most marginalized sections of people. In the normal population group, if incidence is 0.2, prevalence is 0.25%, in these groups, sex workers and gay populations, you know, it would be 7%, 8%, and so on. So they were the ones who were most vulnerable to HIV, and they had to be brought on board. So it was not, even though law-wise, legally, they were all criminalized groups. My workers could have been put behind bars for giving needles to the drug addicts. For, you know, means what happens is you inject yourself a drug and pass on that needle to another. So if I have HIV, I pass it on to the next person. So we would provide them needles saying, throw it away, the disposable needles. Now they could have been put behind bars. So it was completely illegal work. But the paradox is society and government permitted us that space because they were afraid that HIV may affect them too. So that's where the societal sanction was there for HIV/AIDS to do the work they did. It was extremely participatory. And the luck for me was that it was a global priority. You know, that makes a big, huge difference. India was in the defensive, and I was particularly picked and posted over there only because we were being badgered internationally, saying we are hiding, we are not recognizing the epidemic, and we are in denial, and so on. So there was a global consensus to contain HIV/AIDS, which really helped giving HIV/AIDS a very high political profile, being monitored at the Prime Minister's level himself. So those factors did help, but the strategy was homemade. I'm very proud. I mean, the work that my predecessors did and we did, this is one strategy that was unique to India, made by Indians, implemented by Indians, and the success demonstrated globally. This is not recognized by our donors, but you know, this is something that we have not taken the credit we should and can. The beauty is that with all the warts and all of the country, you know, politicians are corrupt, IAS officers are useless, everything, all that, despite all those constraints, we still could forge through on HIV/AIDS, you know, selling condoms. I mean, today you can't, what is that in information broadcasting, saying don't talk about condoms till the children have slept. That was the same statement Sushma Swaraj told me, that no condom ads till 11 o'clock. But condom is a lifesaver. It is something like you take a medicine for your disease. The only way you can stop HIV transmission was promoting condoms. So, you know, condom is a medical. I mean, we would discuss condoms the way we would discuss Aspros or discuss, ampicillin or any other drug in the thing. So it was a very, very important program, and please do read the chapter to get the full benefit of it. Sir, I agree with you. I'm right now, as I speak, battling with the National Medical Commission. It did go to the Parliament once. The Standing Committee sent it back, saying it's a highly centralized, bureaucratized bill. Unfortunately, you know, the vested interests are so strong in medical education that it's not the dialogue with the people that held it back. It was purely inaction, because the government didn't want to change the MCI, because it is Ketan Desai and his MCI and the nexus with the political system that was going well. And therefore, now when the Parliament Standing Committee suo moto, that means on their own volition, there was no application or there was no petition, took a review of the MCI in 2016 and gave one of the most scathing reports. I mean, these are in public domain. I have never in my 36 years career ever come across such a strongly worded report indicting the MCI as this 92nd report of the Parliamentary Standing Committee. So the government could not but take action and bring in the new Medical Commission bill. Now that is full of flaws. The one that has come up has the same highly centralized and highly bureaucratized, and we are in a federal country. Medical education is a concurrent subject, so it has to be more democratic, and therefore it had to go to the Parliamentary Standing Committee. But I am confident that if not in this session, next session it will get through, and the reform of MCI has to be done if health sector in India has to be contained and controlled.
Thanks for your question. I don't think Section 377 is going to have any impact in terms of gay couples pursuing or seeking a reproductive future, because that's long way to go. And I had a conversation with a gay rights activist. And he said, for us, first is legitimacy, then to be able to love and have get married, and then maybe reproduce and have children. But that doesn't mean it's not happening. In India, from what I understand, single men, many gay couples position themselves as single men. Even foreign gay couples are positioning themselves as single men and entering into a surrogacy contract with Indian surrogate mothers and donors and having babies. But it's all very murky and grey. So 377, I doubt it will have an impact on this. But thank you.
377 may set it going. That's basically what. So I think I would want to have all of you join me in thanking both the panelists for kind of, in a very short period of time, give you what all is right and wrong with the Indian health system. And most importantly, I think I would want to sort of reiterate the point which Sujatha was making, and partly which I think also comes from the previous panel, that we get the governments we want. And so if this is not happening, then I think we should at all times keep taking responsibility for the fact that it's not going right. It's not just the fault of the state, it's also us letting them off the hook. And that's what I think we should stop doing. Thank you so very much for being a wonderful audience, and thank you so much, both of you. And absolutely read the book. Both the books are like mind-blowing. I can say it, and on personal experience, something I have done over the last, I could read these books over 2 days because they were that readable.